Coffee time for everybody. Good morning. How are we all? 1, 2, 3. I'm testing the microphone. It's working. It seems to be working anyway. So is it working online? Do we have connection?
Yes,
everybody
everything's
happy?
fine.
Testing. Do we have positives? Thank you very much. See you later. Excellent.
dust, cotton dust, quality dust, bits and dust. عملنا له McGee. Yes.
Yes, we can.
We'll kick off. I can do whatever you want. Forward, backwards. You tell me, and I'll go with what you're saying. Bodadar, good morning, everybody. Welcome, and welcome to people in the room here, and also people that are online, to what is an international conference across the world. We've got people from across the world joining us online today, as well as in the room. So that's really good. My name is Peter Skitt. I'm the Programme Director for the Mid Wales Joint Committee, but I'm also Chair of Rural Healthcare Wales, and I had the privilege of taking that job on from Jack Evershed, who's going to be talking to us later. Thank you, Jack, for that. And what an act to follow Jack was. So thank you, Jack, for your previous chairmanship, which is welcomed, and for your input over the years on that. So from a point of view of why are we here? And I think one of the things that we need to do is, as we go through the day, ask ourselves why we're here. Why is there a need for a conference like this? Why is there a need for us to get together? Why is there a need for rural populations? Okay, so I'm going to do some housekeeping now, if that's okay. Fire escapes are very clearly labelled. Toilets, again, very clearly labelled, but I got it on my list, and otherwise Anna will tell me off if I don't go through the process with everybody. The conference is being broadcast live, as I said earlier, and it is being recorded. Now, I'm going to give you a 2-minute or 2-second privilege of saying that you don't agree with it being recorded, both online and otherwise, because it's important that everybody agrees to that. There's nobody in the room telling me they disagree with it. I'm assuming there's nobody online disagreeing with it at the moment. No? Good, thank you for that. So again, we've got a mix this year of both online presentations, some of which are pre-recorded, etc., and live presentations. The team behind this are very small. We don't have a huge amount of white vans outside on the car park with directors and technical staff in them. So at times we may well get to a position where we have a few glitches from a technical point of view. I promise not to sing during those glitches, and we will work our way through them. So, you know, please understand that as we go through the day. If we could make sure our telephones are off or at least on vibrate. Off is a good thing. People find that really quite privileged to have your phone off for a few hours. Try it, see how it feels, because that's a good thing to have as well. People joining online, if any questions could be put via the Q&A, that would be good, or by virtually raising your hand. We've got spotters around the room that will help me with that, because that is part of the technical achievement process in terms of making sure that we get those seen. And we will then deal with those questions as and when and how we can. Could you please introduce yourselves before you speak, before you ask any questions, because that will be really useful to everybody, particularly around networking and understanding the networks that we've got here. Really important part of this conference is the networking and the post-conference networking, because that is really valuable going forward. So we've got sessions in here today, and we've got sessions in the International Pavilion, which is just over there in that direction, out of this door across to the Cream Building in front of you. And so there'll be some choices in terms of where people are going on that. There will be both the ground floor and the first floor across the yard that will be used. So you will need also to remember to come back at the end of those sessions back into here to have the plenaries, if that's okay. We've got a simultaneous translation for anybody that needs it. If anybody needs to have headphones that hasn't got them, they are on the tables, but if anybody needs them and they haven't got them, then just put your hand up and we can get those to you if you require them. And today, at the end of this meeting, there is a meeting of the Mid Wales Joint Committee, which is the kind of overarching organisation that looks after rural health and care Wales. The meeting will take place here at 4:30 today in this room for the first time, actually, that we've had an autumn meeting in that way, following on from the conference, where presentations of the work that is ongoing there and the successes so far will be talked through and worked through, and that's also available online as well. So in terms of the other elements of the conference, there are posters there that really would be good if you could look at those, mark those, and your sheets from your markings can be handed in. I think there's a box somewhere, isn't there? Is that right, Anna? Just over there on the table, which will be great, because that's an important part of the feedback process for the people who have really put lots of effort into those posters and the work behind those posters. So really important for us to concentrate on those and to get those scores in. Obviously, lunch will be served when we get to the lunch session. And one of the things that I think is really important as well is to take the time today to interact with each other, talk through issues, challenges we're facing, and start to get that network of possible solutions going. We have, I believe, turned the heating off now. Is that right? Yes, good, because otherwise we will all cook, and that's not healthy for us either, is it? So I can see colleagues wafting themselves. Hopefully that will be better in a minute, and we'll get a position where it'll get a bit cooler. People online, could we just remind you to have your microphones off, because it is very pleasant to hear all sorts of people's home lives, but not particularly useful for the conference and not particularly useful for colleagues who are having to monitor that process. So microphones off and cameras off, please, so that we keep a track on where we're at. So really important, no cameras, no microphones until we need them, if that's okay. Okay, so any questions from anyone? Anything that anybody wishes to raise at this point so that we be really clear? No, excellent, good. Have we got the minister lined up early or not? Pre-recorded. Pre-recorded, yes. Okay, so we can move on with that then. So the official opening, we were very privileged to get Cynhadledd Morgan to open the conference forward. And I think, you know, one of the things that I think is important to us is to recognise the fact that we did get into the diary and she has done the opening for us, which, you know, outlines the importance of today and tomorrow and what this means to us in rural Wales. So I'm going to ask the magic people with the buttons to get us into the opening address by Cynhadledd Morgan, MS, Minister for Health and Social Care. If we could do that now, that would be great.
I can't hear any sound.
It says Phil on my piece of paper, so I'm going to fill. In terms of, I did say we might have a few technical glitches, didn't I? In terms of where we go. We did test it earlier. I was here and I did hear the test and it did work. So the right people are running around all over the place, which is always a good thing, and we'll work from there. In terms of the importance of today, I think it's important that also we remember that there's a lot to learn from each other as well. So one of the things that I think is particularly useful is feedback forms. We will be having feedback forms as a part of the conference, and they'll be sent out later this week. It's really important that we get that feedback and that we you know, work on that feedback and improve things for the next year. The numbers coming to this conference are going up every year, year on year, which demonstrates that there is a need and an importance around the work that everybody is doing. So for me, those feedback forms, an honest feedback would be great. Thank you. We're going to try again.
Oh yeah, Claire, can you put the thing off? I mean, where? Sorry.
Okay, so I will hand over to the Minister now. Now that we're all ready to go. So Cynhadledd Morgan, Minister for Health and Social Services.
Today I'm really sorry I can't be with you there in person. It's a challenging landscape that we're living in, and embracing innovation and change in delivering rural health and social care, I think, is more important than ever. And that's why the Welsh Government has decided to focus on creating the optimal conditions for innovation across all of our devolved policy areas, and that includes health and care. And what we've done is we've launched Wales Innovates, which is an innovation strategy for Wales, and that was launched in February this year. Now, I'm proud today to talk about just some of the ways the Welsh Government is driving innovation across the sector. Innovative use of data and technology is a core component of the digital strategy for Wales, which promotes data-driven innovation and the adoption of technologies such as AI, obviously artificial intelligence. Now, we want to foster an environment that enables use of AI across the health and social care sector, whilst ensuring that its utilisation is backed up by firm evidence of efficacy. The establishment of the AI Commission for Health and Social Care is a major step in ensuring a joined-up approach in effective and the ethical use of AI. New and emerging digital devices and systems widen the opportunities for people to stay independent for longer and also contributes to their safety and well-being. For example, technology-enabled care cuts across services and settings, providing opportunities to reassess and reinvent how health and social care is delivered in rural areas. Telehealth allows patients to record and securely share information about their condition and allows professionals to improve treatment and early intervention. It allows citizens to access help through the detection button by automatic detection or via respondent services, and that's happening 24%. Whilst governments engaged in national and local programmes of work to establish remote care across Wales through our Digital Priorities Investment Fund. So, for example, Brexit Advisor, Powys and Hywel Dda have carried out over 24,000 video consultations in 2022-23, with high levels of satisfaction across the services. Another crucial element of delivering care in rural areas is unpaid carers who provide invaluable support to family members and others in their communities across Wales. Pressure on social care, particularly domiciliary care, impacts unpaid carers, and this can be a particular issue in rural areas where local authorities and health boards find it difficult to secure services and people to provide those services. So we've committed £42 million of additional funding to support unpaid carers since January 2022. Carers must have breaks from their caring responsibilities. We're providing an additional £9 million over 3 years for the development and provision of innovative short breaks for carers with a focus on flexibility, creativity and individual choice. This support will move away from reliance on the traditional model of overnight care for a person with care needs. Carers South Wales, in collaboration with Regional Partnership Boards, is managing this scheme. Now, unpaid carers are more likely to be on low income, so we've introduced the Carer Support Fund. That's £4.5 million for the 3 year, which provides payments for carers on low incomes to buy essential items. Carers also need appropriate information and support when the cared for person is admitted or discharged from hospital. So we provided an additional £1 million to health boards this year to facilitate the support. Many people are already able to access the fantastic resources available within our communities, or they can turn to their friends and family for help and advice. But this can be really difficult for some, and that's where social prescribing can help. Now, social prescribing is an umbrella term that describes a person-centred approach to connecting people to local community assets to better manage their own health and well-being. Community assets include community groups, interventions and services which could be delivered online or in person, as well as buildings, land, or even a person. Social prescribing can empower individuals to recognise their own needs, strengths, and personal assets. Now, lots of you will know social prescribing across Wales is not new. It's woven into the very fabric of how Welsh Government empowers people and communities. So what we're doing now is we're developing a national framework, which is a key programme for government commitment. Now, one of the benefits of social prescribing is that it can provide people with more meaningful connection, perhaps to nature, and appreciation of the role of the arts and culture, and it's supporting their well-being. social prescribing can provide multiple benefits, such as improved mental well-being, reduction of depression, anxiety, and stress-related symptoms, improved self-esteem, confidence and mood, and increased social contact, inclusion, and a real sense of belonging. Now, given that estimates show that around 20% of patients consult their GP for primarily social issues, the potential for social prescribing to reduce impact on frontline services is evident if these alternatives are more easily and more widely available. Now, one of the big challenges facing our health and social care workforce is the recruitment and retention of staff. Remote and rural recruitment represents a unique challenge that requires innovative solutions. As a government, we've shown our commitment to improving pay for social care workers by investing a further £17 million this financial year to ensure everybody who works as a care worker in Wales continues to receive at least the real living wage. As well as our commitment to the real living wage, we've invested £10 million over 3 years in the social work of nursing. And we've also offered an additional £5,000 to incentivise dentists to undertake their training in rural areas, places like West Wales. And through our funding for social care workers, local authorities are growing their own schemes to support paid employment and social work training. In the health sector, the new independent North Wales Medical School will help us train the medical staff we need for the future. Establishing this school will enable us to train more medical students here in Wales and ensure we distribute both training opportunities and the provision of qualified doctors across rural North Wales. Health Education and Improvement Wales, or HGIW, has commissioned 2 additional adult nursing programs for people in Middle West Wales who previously may not have been able to access training. Full-time programmes now serve the North Cynhadledd University Health Board, led by RHCW University, in addition to the dispersed training programme serving Cynhadledd and Powys Teaching Health Board. These investments and programmes of works are for the longer term, and we expect it will take time to feel the benefit of these commitments. But we're not only thinking about recruitment and retention in health and social care. We're also thinking about continuing professional development, or CPD, for these workers, which improves not just the individual, but the work they do, and that raises the quality of the services and improves career development. Since the pandemic, social care workers have recognised that many workers have gained valuable on-the-job training, so they've reduced the number of hours needed for registration. HGIW is currently developing the first CPD strategy for Wales, which will set clear principles and expectations for the future. A key part of that strategy will be to identify priorities for CPD across Wales and to establish a commitment for all staff to have time to learn. HGIW has also implemented a new learning management system called the TSB, which will support and improve access and quality of CPD. The revalidation support unit in HGIW continues to provide educational opportunities for GPs and wider primary care. This includes live webinars and online content, allowing resources to be accessed remotely at a time and place to suit individual needs. CPD is essential to support, develop and maintain the skills of our rural health and social care workforce, with clear benefits for workforce well-being, retention and quality. And it feeds back into our intention to have an innovative health and social care sector across rural Wales. Gael diolch eto i'r trefnwyr am gyfle siarad gyda chi heddiw ac yn gobeithio bydd y ganharddiad eleni yn gyfle i ddathlu sydd wedi gyflawni ac i edrych at dyfodol iechyd a gofal wledig. Thanks again to our board for the opportunity to address you today, and I hope this year's conference is an opportunity to celebrate achievements, but also to look to the future of rural health and care. required.
Thank you, Minister, for that. And I'm told by my associates that I should apologise for those people online who couldn't see the Minister. What we'll do is we will send a link out to that presentation so that people can see that going forward. There are a few seats at the tables if people want those, but if they prefer to sit in an audience row at the back, that's absolutely fine. As well, so entirely up to you in terms of how we go with that. So we're into plenary number 1, which brings back Jack Evershed in a different cap than he wore previously, and he's bringing with him Ben Eaton, the Strategic Director and Organisational Strategy and Engagement for CLICE. They're going to talk to us about strengthening people's voices in rural communities. And welcome, guys, if you want to come up and take us into that agenda. Thank you.
Ben's got the presentation. Okie dokie. There we are. I'm still getting told what to do by Anna, although I thought I'd escaped that. Good morning, all. Just by way of introduction, when I was having a quick chat to Peter, privilege was not the word he used for following my chairmanship, but I shan't repeat what he called it. And also, for those of you who've read the programme, despite the fact that I'm a farmer, I promise I've got another jumper. As I say, it's a pleasure to be back, especially not to be chairing the conference. As many of you will know, Rural Health and Care Wales was a product of the Mid Wales Healthcare Collaborative, which came about after a review of the healthcare services across Mid Wales. And the primary recommendation from that review was that we should re-establish communication between the people and patients of Mid Wales and their care providers. And hopefully, eventually, that would lead to mutual respect and trust. I think we've proven over the last 9 years that things are much better if people are actually involved in the design and evaluation of their care services. The conclusions to me from our work in Mid Wales was that if people feel listened to rather than orphaned, as it was described in the report, that is a good end in itself. I think that is very important. People feel better if at least they feel they're being listened to. Another thing is that the health boards better understand the patient experience and the patient's wishes and the people's wishes for their care services. And also it goes the other way. Patients and people begin to understand the dilemmas that the health boards face in delivering those services. They are numerous and we all know what they are. Another conclusion was that due to the incredibly complex nature of the care pathways in Mid Wales, that we needed to know where we actually represented those views and experiences. We couldn't just represent them to the health board in the area that they lived in, because their care pathways tended to cross both geographical and institutional boundaries. Anyone who's been to any of these conferences will have heard me bang on about boundaries over many years. And fourthly, to my mind, what those 9 years has shown me is that change can happen. The Minister has mentioned the developments in training for a rural workforce. Well, I think we can take quite a lot of credit for that here in Mid Wales. We started the programme of having GPs being trained in that ghastly term longitudinal placement. They were placed in Mid Wales so that they experience what being a GP in the rural areas were. And those developments have led on to the development of the school in North Wales, which will hopefully carry that work on. We have nurses being trained in Mid Wales because the nurses required for this area need to be trained differently to the urban model that was being delivered. We also won the argument about whether Brongleis Hospital was an important hospital, needed to remain as a district general hospital. We have developments happening across the patch, the new hospital in Machynlleth. We've got primary care centres, or whatever they're called, across the patch, where we have health, social care and volunteers all working together to deliver services. And on a personal note, I'd just like to say that my mum was very ill over Christmas last year, and she came home on a palliative care pathway. And we had the most fantastic service for the rest of mum's life. It could not have been better. She was happy, comfortable. We were supported. And I have to say, the people who walked through the door, I can't tell you, were they NHS staff, were they social care staff, or were they voluntary staff? I know they were all three involved. I had no idea who was what. And that sort of collaborative team is fantastic and what we need for the future. Now, I'm not going to stand here and pretend that everything is rosy in Mid Wales as a result of the Mid Wales Healthcare Collaborative. But it doesn't feel quite as much that rural communities are more penalised than urban communities. A lot of the problems we have are systemic in the NHS, access to GPs, lack of social care workers. It doesn't feel quite so much that rural communities are being penalised as much as they were. And I think those in this room can take a lot of credit for that. So my conclusions were that if we want to represent the views of people and patients, we need to be able to work across all boundaries, geographical institutions. And I felt so strongly about it that for my midlife crisis, I did an MBA at Aberystwyth rather than buy a big motorbike. A lot safer, I can tell you, those reaching a certain age. And for my thesis, I did a piece on why I thought the governance structure around CHCs meant that they were hamstrung in representing the views of patients and public. The CHCs undoubtedly were doing fantastic work, but actually their governance structure meant it couldn't be as good as it could have been. So when Slice was being formed, I saw an opportunity that this presented. Not only has it got a national remit, it also works across health and social care. So I joined the board with the intention of building on the good work that the CHCs have done and what we did here in Mid Wales. And I wanted to make sure that all communities across Wales who felt, as it was said in the report, orphaned, were able to engage with their statutory bodies providing them care. How are we going to do that? Well, that's the joy of being a non-exec. So at that moment in time, I should pass over to Ben, who will explain what we're hoping to do to start to achieve those goals. Thank you.
Thank you very much, Jack, I think, and thank you for inviting me to speak today. I wanted to explain a little bit about Slice, how we're set up and how we are planning to involve and strengthen the voices in rural communities. Some of you, as you've just heard, we were born from the CHCs. Our remit is expanded into social care. And we came into being in April earlier this year. We are very much setting ourselves up to work in a local, regional and national way. By that, we mean we want to listen to local people's views so that we can tackle regional challenges and also help influence national policy making and decisions that are taken which affect all parts of Wales. With the boards and our staff and our volunteers, we want to make it our mission to be an inclusive, independent and leading voice for health and social care services across Wales. We have roughly 100 staff. We're in 12 locations across all of Wales, and our footprint follows that of the regional partnership boards. We rely on volunteers, of which we have some in the room with us today, and we very much need to expand that to make sure that we're hearing from local people with local views as we move forward. Jack mentioned the board, of which he's a non-executive member. We have 7 non-executive members from across all parts of Wales, and the chair of the board is Professor Medwyn Hughes, and our chief executive, Alison, also sits on the board. These are all ministerial appointments that have to go through the rigour of the public appointments process, and they're setting our strategy and our ways of working as we move forward. So the 3 core activities of CLICE, the first is to engage and gather people's views, be that on health or social services. And as you heard me say, we want to work in a local and regional way. So I'll give some examples of how we're doing that in rural communities a bit later, but we want to take our service out into the communities, not ask communities to come to us with their views all of the time. Our second core activity of work is a new power that was given to us through the Act, and that is making representations. So working with decision makers at a local, regional, national level through making representations. So we do that every day, be that informal discussions representing citizens' voice in meetings with the health board, with the local authority, our engagement events, or through the more formal representations process where we can formally write to the NHS or the local authorities, or sometimes make referrals to the minister. Our third area of activity is our complaints advocacy service. So we have trained advocates that work across all parts of Wales who can help support people who are going through the official complaints process, either in health or in social care, to navigate those processes and make sure that their voices are heard. We've also joined up that work with our insights gathering. So it's an early indicator where there's problems, and we can seek to involve people's voices in those issues which were being flagged up. So what does that mean for the NHS and social care partners? The Act is very clear that NHS and local authorities are under a duty to promote our activities so people know about us. They also must make arrangements to cooperate with us and share data if there's something that we would like to inform our representations. And the NHS and local authorities have to help us hear from people at the point at which they're receiving their service. So we can go into health and social care services and hear from people as they're receiving the services. And as I said, the last point is about representations, but the Act also puts a duty upon the NHS and local authorities to listen to and respond to the things that we're saying to them, be that in meetings or formal written representations. So 3 core areas that the board and our executive team would like us to focus on. Is the being an organisation that's led by the people's priorities, not our priorities. So we need to hear from all parts of Wales to inform our strategies and our plans and to take those forward, and to be a very accessible and inclusive organisation. to hear from the views and needs of diverse populations across Wales to make sure that no one is excluded, and to be an organisation that seeks to build relationships, not to do things on our own in silos. So, to how we are setting ourselves up to strengthen people's voices in rural communities. To ensure that no one's excluded, we have set ourselves up with some core ideas and ways of working, which in our first 6 months are just starting to develop. So we've created an internal working group that's focusing on rural issues. So they're looking at things at the moment, such as rural transport, accessibility issues, digital exclusion, cross-border inequities, and cross-boundary challenges that we experience in Wales. We are also adjusting our internal policies and procedures to make sure that we're thinking about the impact of things that we do on rural communities, such as changing our impact assessments to include the impact on rural communities and digital exclusion. We are testing new ways of working that, as I say, take us out into the communities, and I'll give a couple of examples of that in a minute. And we are developing new partnerships and joint projects around rural issues. So we have some new national organisations, such as working with the Young Farmers Cymru, Care Forum Wales, and also more regionally with organisations such as Community Connectors, the Fire Brigade, and local care homes, all to explore new ways of working to get the voice of people into the services that they are receiving. So a couple of examples of our new ways of working. We have taken our Paris colleagues, some of which are here today, have been trialling a new hyper-local approach where we take our services out into a local council or a local town, and we have an intense period of activity in things like pharmacies, community centres, libraries, shops, and we hear from those communities their views on health and social care and gather their insights on what could be better. That's working really well. I think it's useful for both the local authorities and the NHS to hear that really local view and for them to help move with service changes. In West Wales, our colleagues, in an effort to work with social care colleagues, took an approach where they have met with every, or will be meeting with every care home manager. They've gone out, they've met, they've had a cup of tea, they've got to know the staff, and they've explained what we're about, so that when we come to hear people's views on the service, at the point of service, they know what to expect. We need to actively promote our work so that people understand what we do and are not afraid to come forward with their views. We've learned from something that we did earlier in the year where our approach to promotion didn't work in rural communities. We weren't seen, we weren't recognised. So we're working on a new marketing and communication campaign that's going to reflect the individual needs of each of the regions, be that rural, urban communities or a mix of both. I just wanted to draw out a couple of priorities going forward from our 100-day plan and our new strategic annual plan, which is published today. So we heard earlier Jack mention the issues around access to GPs. So we're launching 2 national projects and campaigns where we want to seek the views of people across all of Wales and help involve those different services in the design. So we are looking at primary care, GPs, dentists and pharmacies, and we'll also be doing a project on health and care in the community following a hospital stay, which will come the view of the community care as well as things like discharge from hospital. Along with that, we'll continue to work and advise on the national, regional and local service changes that have the greatest impact on communities. So national service changes, we've been providing some advice and guidance on the emergency medical retrieval and transfer service review. We've also been working with each of the health boards as they look to seek community involvement on their plans for service changes ahead of the winter. So what we'd like you to do, can you raise awareness of our organisation with your communities and your partners? Work with us to develop our ways of working and share your voices so communities can be heard. Help us to understand the priorities and challenges for health and social care in your areas. Going forward, we want to continue to work on the local, regional and national basis, but we don't want to be an organisation that just focuses on the issues. We also want to look and promote best practice and innovation. So I'm very much looking forward to hearing some of the talks and looking at some of the posters and some of the breakouts later. And with that, I think we'll invite any questions.
Thank you for that. In terms of next stage, questions from anyone in a controlled way, I will referee, if that's okay. We've got some roving microphones that are going to be flying around the room by helicopter to you. So I'm happy to open up to any questions from anyone. We've got one over there. Thank you. Just one second, because we can't hear you online if you don't have the microphone, apparently, I'm told by my left-hand woman.
Okay. About the new nursing program that we now have at Aberystwyth University, and we like to think that we do things slightly differently out of the box, because we have to adapt, because it's a very rural community. So we have two exciting initiatives that are currently ongoing that we'd like to know if LICE, if I correct it properly, would like to be involved in, please. Number one is we have a service user forum. So we want people that use all services in the NHS and local charities to come in and comment on our curriculum and assist us in interviews, and also to promote what we do to ensure it's fully inclusive for the nurses or the student nurses that train with us. But we also have a new initiative that Nicole and I will be presenting to you later on regarding social prescribing. It's called Green Gatherings, and we're wondering if you'd also like to come and participate in that with us also, please. Thank you.
Jack, you wanted to comment on that? I expect so.
Surely not.
We can't be on the camera together. No.
Yeah, thanks, Lisa. On the second point on social prescribing, Mid Wales Healthcare Collaborative, Rural Healthcare Wales have been heavily involved with social prescribing from the very beginning, and I am incredibly keen on it. I sit on the board, but I don't think it's going to be a hard sell to the executive team for us to be involved in such things. And as far as the getting patients, public involved with the nursing school, as you know, I've been a prime mover in that as well. I think it strengthens the selection of the nursing candidates. I've always mentioned here, I think in the past, that in Canada, when they couldn't train a workforce suitable for them for the remote parts of Canada, and where we're talking rural and remote, Canada makes us look really quite cosmopolitan. In the end, a chap decided, oh God, and he set up the Northern Ontario School of Medicine just out of the blue. And I had a chat to him and I said, how do you select your candidates for your school where you want a rural workforce to be produced? And I quoted my two sons. I have one son who did not work terribly hard at school, and he's quite able academically, but his results would not have allowed him to get to medical school. The other son, incredibly academic, would have sailed through. I know which one of those would make a better doctor, and it's not the one who was the high-flying academic. And also, which of those wants to live on the farm? Not the high-flying academic. So the selection process where we purely base it on academia, and to get into medical school, the qualifications, they were going back to GCSEs and requiring stupidly good results in GCSEs. That is not necessarily the best way of recruiting people who will wish to work in a rural environment. So yes and yes, as far as I'm concerned. You better ask the exec though, if I'm speaking out of turn.
Yes, please. We are working with HIW, the NMC, the GMC, and some of the universities in Wales as well to try and to get the knowledge of Llais in with those that are training. But yes, definitely, we'd love to be involved.
Not only students based on their academic achievement, but also we ensure that they all go through a values-based interview as well. So we really are looking at people that have genuine compassion and empathy to bring to business. So yeah, we totally agree with you. Thank you.
Thank you guys for that. I think we've got a question online. Oh, hello, Tom. Have you got a question for us?
If I may, Peter, and nice to see you and Jack. Sorry I can't be with you this year down in Bilthwells. I am a registered Llais volunteer, and I have been working on a number of regional footprint sort of issues. And I've tried very hard to encourage people in local areas to sign up as volunteers. There's no shortage of volunteers as far as healthcare is concerned. We have nearly 30 of them on the committee in our local hospital and the Friends. We have a focus group in the GP surgery, and I find those in lots of places I go to. So why is it that they are not encouraged, not willing to join Llais at the moment? And it's because essentially Llais doesn't have any local structure. The CHCs did have a structure in each of the counties, and healthcare is local. You know, what happens over on the far east of North Wales is of interest, but nothing more as far as the people in the northwest where I am, where I live there. What can you do to produce a real structure for locality instead of simply talking about things being sort of local?
Ben, do you want to come on?
I'm ducking that one.
Yeah. I thought you might, Jeff.
Thank you. So I touched upon earlier the hyper-local approach that our colleagues in Powys have taken. That's something that we are planning to roll out across all regions across Wales. So that'll be one way in which we get that absolutely hyper-local difference and involve people in that. In terms of volunteering, each of the regions are also setting up individual fora to hear and involve volunteers, to involve them in things like the service changes and planning, and make sure that they're fully informed about that. We've also included in our national plan something around the kind of consultation fatigue and constant and pull of volunteers and the public in providing their voice, and something we're looking to do as we move forward. Be quite a challenge, but to bring all of those organisations together, be that across boundary, to engage on single thematic issues rather than doing it separately, and drawing lots of different volunteers and different members of the public in at different times on the same issues. I hope that answers the question.
Thanks for that, Ben.
Am I allowed to come back a moment, Peter?
You are allowed for one moment, Tom. Yeah.
Thank you. I much appreciate what one's doing sort of at a national level, but what one needs is a plan locally. We have 3 clusters in Gwynedd, each of whom is very different. And Llais needs a different plan for each of those because the problems are different and the solutions are different. But at the moment, there's no structure in order to address healthcare at the regional level. And I think that needs to be addressed so that we can really make a success of Llais in Wales.
Thanks for that, Tom. And I think that's agreed. I think the thinking is happening, and you know, it's early days. I think for a national organisation to be getting every level sorted. So I think you know, there is a recognition that local is the answer, and I think inclusivity was one of the points that you made, Ben, in terms of working forward. So thank you for that point. Have we got any other questions in the room at this stage? Any other questions online, team? No, okay. Thank you for that. Jack wants to take the microphone again, so I'll let Jack do that.
To my mind, we fully appreciate that what Tom was saying, that problems are very different in very local areas, and we need to get a grasp on that. But I would personally be very wary of saying that the board thinks we should have this structure. I think that mitigates against innovation and people doing things differently, like what the work that's going on in Paris, which is the hyper-local visits, is a fantastic way of finding out what a very small community are experiencing. I am not going to sit at the board and say, make it so across Wales. What I'm going to say is, please, can you encourage people across Wales to come up with really interesting ways of doing this stuff that's different and will actually achieve that. I think to impose a structure would be counterproductive.
Thank you, Jack. Inclusivity and public voice. Thank you very much for that. Because we are 5 minutes ahead of schedule, nothing to do with the chairmanship, of course. We could, if everybody would wish to have one, have a quick comfort break and then roll on at 11 with Veronica, who I know is here and ready, if that's okay with everybody. Thank you very much. Thank you to Ben and Jack for that.
Okay, so I can just leave that like.
across the camera off. That's me there. You see me? I don't want that really. We're on mute.
I'm Jackie Price. I'm nice to meet you.
Gone, pear-shaped.
Come on, Peter.
No, that would be good. Veronica, where are you? Are you here? Good, excellent. As long as you're here, that's the main thing. Okay, I'm going to kick us off then, if that's okay, with our next session, which is a discussion. Again, really interesting, isn't it, in terms of the idea of being a rural clinician in some way, and how do you keep people in rural clinical jobs, some of which are single clinicians that are potentially isolated, and how do they network with each other and how do they work with each other? We've been asked in Rural Health and Care Wales to do some work on that as well, in terms of a kind of social event and get together for clinicians in rural environments, and I do think we could underestimate that. So with nothing more to add to that, other than to ask Veronica Razik to take the platform now. And Veronica is going to talk to us about building global network to support current and future rural clinicians. So Veronica, over to you. Thank you very much.
Hi everyone, it's a pleasure to be with you here today. Just going to wait a moment for my presentation to go up. So my name is Veronica Razik and I'm a GP and a passionate rural health advocate. So I am going to start with a very ambitious technical slide. So if you all could bring out those mobile phones that you were kindly asked to put away and just scan the QR code, because that's the quickest way. And really, I'd like to find out a little bit about why you're working in rural health and care. Hopefully that's given you enough time. We're going to move on, and I hope everyone online has also managed to use the QR code. And while you're answering that question, I'm going to tell you 2 reasons why I'm working in rural health. So the first one is a childhood experience. So when I was 10 years old, I was living in rural North Queensland, Australia, with my family, and I was a happy, active child. And then one day after a school excursion, I became unwell. And everyone thought it was a bit of a cough and a cold, I would get better. But 2 weeks in, I was extremely unwell. And I ended up being admitted to the local hospital with bilateral pneumonia. And that was really my first encounter with healthcare and being unwell. And I think it helped me understand just how vulnerable illness or accidents can make people. And I think that's a lot more pronounced in rural areas. The second experience was while I was a just starting out doctor. So I was living in Croatia at the time and doing my family medicine specialty training. And I was about halfway through and I was very excited and motivated. I was happy I was doing family medicine. And then I got very suddenly deployed to a rural area on the border with Hungary, and a town of 1,700 people who all became my patients. And it was my first experience as a single-handed rural doctor. And I was very, very motivated to make it work, but I was very, very underprepared to make it work. And over the next 6 months, I burnt out horribly. So I was seeing 60 to 100 people a day, and I had no additional support, no additional rural health training. So that led me to moving to the UK, in short. But that negative experience has also been a catalyst for my ongoing work with WONCA on an international level and my ongoing rural health advocacy. So a good thing in the bad. Not sure this is going to work. So this was supposed to be your word cloud. I will try and find it later because I'm sure I've got it on the platform, but thank you for sharing your reasons if you have shared. So my next slide is just a little bit of an overview of what I'm going to try to quickly whiz through today. I wanted to talk a little bit about what's going on at a European level and what projects I've been involved with over the last 8 or so years. So first, WONCA. I don't know how many of you know about WONCA, but WONCA is the World Organization of Family Doctors, and it represents about 500,000 family doctors across the world. It's divided into regions. The region relevant for us is WONCA Europe, and within WONCA Europe, there are 6 networks, which the easiest way to describe them is they have an interest area within primary care, and EUREPA is one of those networks. So EUREPA is the European Rural and Isolated Practitioner Association, and it was founded in 1997, and it has very strong Welsh roots, really, because there are 2 people from Wales that have been involved in founding it and the ongoing work that's been going on within EUREPA, and that's Dr. John Wyn-Jones and Jane Randall-Smith, who's here in the room with us today, and they continue to be very actively involved in all of the work that's being done on European rural health and global rural health. The other thing I wanted to reflect on is that EUREPA had a charter that they published in 1997, which was the European Charter for Rural Practice. And then they have subsequently updated it in 2006, but we've recently, last year in 2022, published a new blueprint for rural practice in Europe, which is a lot more comprehensive than the original charter. And you can find that at eurepa.org, and I do encourage you to have a look at the charter. So I chose this quote from the original charter because I think it helps us reflect on the situation 25 or 30 years ago, and really we're in much the same situation today. So we still are looking to revitalize and regenerate rural communities, and there's still a lot of work to be done on equity for rural health. I very, very briefly wanted to reflect on just a few points from the blueprint. So the blueprint speaks about a vision for the next 25 years for rural practice in Europe. And it puts a lot of focus on realizing health equity. And I think that's really important. And the other thing that's important is the emphasis on the primary healthcare team as the way towards achieving health equity, because without that, we can't achieve universal healthcare coverage. And without rural areas achieving universal healthcare coverage, the world is not going to reach that goal either. The second thing I wanted to emphasize was recognizing the multifaceted nature of rural practice and the different skills that are needed to practice in a rural area. And part of that is thinking about, well, how do we develop rural training pathways? Wales is lucky in a way because it started the work on developing rural training pathways for primary care, but many countries in Europe have absolutely no training pathway. And then developing and nurturing that rural healthcare workforce is also important. So investing in leadership, mentorship, investing in rural academia, despite what was said before. So we need that evidence to then be able to present a case to the people that are making decisions. And the last point is rural health advocacy. So I think EUREPA and organizations such as this one have a big role in advocating for rural health for their local communities. And then I wanted to reflect a bit on Europe. So Europe covers a large area. it has lots of different countries, lots of different cultures, lots of different health systems, and each of those will have their own specific context and needs that we would need to adjust to help with improving rural health. And rural Europe covers 83% of the European territory and represents 30% of the population, so some 137 million people, which is not a small amount. And I wanted to also say some positive things have been happening on the European Union level. So over the last couple of years, the European Union has developed a rural vision for rural areas to 2040. And this is an overarching plan for how they would like to see rural development happen over the coming years. And as part of this, they've also founded the Rural Pact, which was created in 2021. And its function is basically like a coordination office to try and help all the different actors that are interested in working in rural areas work together cohesively. And these are their three main objectives. So one is getting the voice of rural communities heard. Two is structuring and enabling that collaboration. And three is encouraging and monitoring the actions towards the vision. And there is a website there, but if you type in Rural Pact EU, it will come up as well. Part of the work that I've been doing with Eureka is trying to foster those relationships with the European Union and the Rural Pact in particular. And as part of that, one of the representatives came to our forum, which was in Romania in October this year, to help strengthen that relationship. And a further outcome of that has been that we are collaborating on a joint workshop on the 30th of November with the Rural Pact, WHO and OECD to further talk about what is the state of primary care access for Europe in rural areas. And it's really important, I wanted to emphasize, to step out of our usual silos and to go to events that are complete other sector and to speak with people from those sectors to understand what is their perspective on what's happening in rural healthcare and what the barriers are and what they perceive to be the barriers, and to work together with them on alleviating those. And then from the Eureka side, I wanted to also invite you to our 13th Rural Health Forum, which is happening in Lincoln in June. And this is going to be a very good opportunity to raise awareness around rural healthcare in the UK. So if you can, please do consider joining. And we've got some flyers to share with you if you're interested in those as well. And the next thing I wanted to talk about is Rural Seeds. So Rural Seeds is a global network for students and early career rural health professionals, with the aim of providing a place for them to share their experiences, exchange ideas about rural health, learn more about rural health, and also get involved with advocating for rural health. So I wanted to share a little bit about the story of how this happened, and perhaps inspire some other people to consider setting up their own initiative of this kind. So back in 2015, I attended the Wonka Rural Health Conference in Dubrovnik, because I was still in Croatia at the time. And I was able to participate in developing a student and young doctor program. And through that, I got to know a lot of the international rural doctors that came through, and I got to learn from their experiences. But another important thing that happened was that I met other students and early career professionals, and we started talking. And we realized that other than Australia and Canada and these very good examples of what rural training could be, most countries in the world don't have access to rural training pathways and shy away very much from being sent to work in a rural area for various reasons. So this young lady at the bottom is Mayara Floss, and she's one of the people that I started talking to a lot more intensely in the coming weeks. And she came up with the idea of, well, why couldn't we start with what we have? We've got online video conferencing. Could we start up some kind of online conversation about rural health and just invite everyone who's interested to come and talk and discuss the issues that they're facing? So this was the first Rural Family Medicine Cafe in October of 2015, so about 6 months after the conference. And it became very popular. We held it every single month. We had different topics, so from rural mental health, rural leadership, women in rural health, urban rural divides, all sorts of topics. And there are more than 50 rural family medicine cafes available to watch online on our YouTube channel if you're interested. The next step in building the network was to formalize the network. So initially we didn't see this as a network when we first started out. We just thought, what can we do to get a conversation going? But over the next 2 years, and through doing the cafes, we realized that there really was a large interest globally. And the reason we decided to go global was locally what often happens if you're at medical school and you say, I'm thinking about being a family medicine doctor or a GP. Everyone's like, why would you do that? Why don't you want to be a surgeon or something else? And on top of that, if you then go, well, I want to be a rural family doctor, you're really like, everyone's just turned their back on you. It's like lost cause. And that was an experience that a lot of my colleagues have had. So this was a way to find other people that have that same interest and passion as you do and start talking about it. And in 2017, we launched the global network at the Cairns conference. And we took that opportunity as well to get together with the other students and young doctors that were at the conference. And we put together a call to action in 2017. And that call to action focused on 3 areas. So it focused on education and training, co-empowerment for us as future clinicians, but also for the community, and communication. So how things are communicated about rural health and rural health training. And we also put out an action plan at the bottom of that call to action with concrete steps, some of which we have taken over the following years. And the other thing I wanted to emphasize was that Rural Seeds was envisioned as a action-based kind of program or project. So we based all of our activities around different projects, and these were the first 4 that we did. So the first one was the Rural Family Medicine Cafe, which I mentioned. The second one was the Rural Health Success Stories, which was basically a blog where we encouraged everyone to share their positive, ideally, stories about their experience in rural health to get a bit of a sense of what it's like to practice in a rural area. The third one, which we're very proud about, is the Mentor Mentee, which was an innovative online mentoring program, and it connected students, young clinicians with more experienced senior clinicians. And we've just had our second round this year, and it's just finishing up now, and we're hoping to put out a report about that soon. And the fourth one is Rural Videos, which does what it says. So it's basically a project that's developed videos about rural health, and I'm hopefully going to be able to share one which talks about the importance of rural healthcare workers. And no. Am I able to just go onto YouTube?
You can end the slide.
Bear with us.
You know where it is.
Just go on YouTube and find it.
I don't know what you can see on the screen. There.
That'll do.
Yeah.
No, I'm not going to find this one. Let's go back to the presentation. I'm going to give up. I'm going to give up. But you can search for Rural Seeds on YouTube and the rural health videos, or go to the website ruralseeds.net, and it will show you the videos and the cafe and everything else that we've done, including some webinars which we've done in the past year.
I don't know if it's sharing or not. I have to share again. You want to go back to your presentation?
Yes. Listen. All right. The other thing that I wanted to emphasize is during the development of this network, there were obviously various challenges which came up along the way. So initially, we were 4 founding Rural Seas ambassadors, and we worked across different time zones. And later on, we brought on regional ambassadors. So now we have between 15 and 20, depending on the time, ambassadors across the world. And we have challenges meeting, we have challenges with people having life events or training issues, study times. So all of these things had to be factored in. But the thing I wanted to leave you with here is a quote that we used at the end of our call to action, which basically emphasizes the importance of young people getting involved and the power that they have to change things. Because obviously you have a long time to work on these things. And I've been working on this for 8 years, and I expect to be working on it for a lot longer. And following this, I'd like to invite those who might be interested to become Rural Seas ambassadors, because we're currently in the process of looking for new ambassadors, and we've got 2 places available for the European region. If you know other people who might be interested, please feel free to share it with them. Come up and speak with me during the day as well. I'm very happy to answer questions. The other thing I've been working on over the past year is the Rural Road to Health podcast. So this came out of a need that I've received to further develop the discussion around rural health and to open it up a little bit wider and start looking towards other sectors a bit more and towards the policy space. So over the past 10 months or so, I've been running an interview-based podcast, and I've had 25 episodes in this first season, which is now closing at the end of the year. I've had 18 interviews with people from 13 countries. There's students, academics, family doctors, people from other kind of community organizations and public health sector. And it's been a really great experience. I've learned a lot, and I hope that this could be a tool to share with students, to use, to listen to just because you're interested. So please do have a look and have a listen. And I'm hoping to start the new season from January next year as well. The final thing I wanted to mention is yet another thing I decided to do for some reason, is a social enterprise that I've decided to launch this October, which focuses on the rural health and policy space. So a lot of the discussion that we've already heard today talks about the importance of getting the community voice heard. And one of the main barriers to getting the community voice heard is the capacity of the community and other organizations in rural areas. So I've envisioned this, and it's very early days, so I'm very open to collaboration and support and everything else, is to develop some kind of educational tools that can be used by communities, organizations, and that really tries to explain what is policy, how does the policy space work, how do you interact with it, how do communities get their voice heard. And my idea is to let the community then say what they have to say, but just to give them the tools to do that. So the idea is to try and do it through a 3-step process. So connection and collaboration, so connecting different organizations working in the space, knowledge translation, helping them understand what certain terms mean, because even for me, I don't always understand what the policy decision-making people are saying. And 3, helping them to strengthen their advocacy efforts. So that's just a brief mention, and please do come and speak with me if it's something that you're interested in. And finally, I just wanted to say that through this process, the things that I've learned is it's important to start with your why. It's important to learn with and from others. It's important to build networks because they can give you so much and help you get a lot further than you would on your own. Share your stories, especially if you're working in rural areas. Share what it's like with other people who might be interested in rural careers. And don't be afraid to innovate and explore. Sometimes failing leaves you in a very interesting place. So give it a go, even if you think it's a crazy idea. Thank you very much.
Thank you, Veronica. That reminds me of I don't know whether everybody's seen the video, the lone dancer. You know, the person that starts to dance and the rest of the people join in from the crowd. And I think, you know, we've got that going, haven't we? And I think that's really important. It also brings about thinking around appointments and training. We train people, we appoint them to roles, and then what do we do? And we tick the box. We say we've got people in training, we've got people in post, or we've got a GP for that practice now. Tick the box. But do we keep them? Do we stop them? The mention of burning out. Do we stop them burning out? Do we stop them and help them and work with them and support them in a networked, professional way? So really good stuff in terms of how we keep people in rural practice and how we maintain that, because it's easier to maybe fall back into a different world. So really good reminders and important reminders of that. We've got a question online from Vasilio, who is in Swansea Bay University Health Board. How do we participate in the cafe? I think you kind of answered that really, but I don't know whether there's a clearer way of explaining that.
So the cafe is currently not running actively anymore because it took a lot of work, but instead we designed a guideline for how anyone can run a cafe, which is available on our website. And there have been local groups that have run cafes either in person or online, and this helped us bridge the language barrier. So one of the things that we came across, obviously working as a global network, was if people couldn't speak English, they didn't really engage. So we tried to find a way around that. And we have had people then go off and have cafes in Spanish or French or some other language. And yeah, so I'd say if they're interested, they might want to consider trying to host a cafe in their local university or country.
Brilliant. And you've got a link to that. You never know, we may even have one at Cymraeg. So in terms of questions in the room, have we got any questions in the room that anybody wishes to ask? Okay, the lady at the front here. The rover's coming. She's here, but she's been creeping up behind you.
In rural health, but actually what it means to live in a rural environment and to have health issues. I did the induction to the health board, and one of the things that I remember was hearing the numbers in terms of population, and I heard the number and I expected it to be followed by older people or people needing healthcare, and then understood that that was the total population. And having come from kind of North London, Hertfordshire area, I was a bit taken aback that that covered such an enormous geographical area. Like, that's the total number of people, good grief. I'm only been here for 20, 30 years on holiday, but I think it's that you don't really understand either rural health or what it's like to work as a health professional in rural health until you're actually here. And I'm not sure that a year down the line, I've gained a lot of understanding, but that understanding has come because I need to really understand this. I need to, it's not given, it's not offered. And I wonder whether there's something that we need to be thinking about in terms of how people, hospital workers, health professionals, nurses, the whole group of people who are working in this in rural health to really understand what that means.
I'm not sure I can answer that, but I think that it's really important to think about how we've structured our training, how we've structured medical training in general. Historically, universities are based in cities. Academics are based in cities. They're from cities a lot of the time, which automatically leaves a big blind spot for what you're going to be talking about and what you're going to be reflecting on and the type of cases you speak about. And it leaves people feeling like that's a very big unknown. And as a new clinician, that's very scary to be I was deployed, but to start working in an area which you were not trained for and which no context has been provided for, and to have to learn on the go, especially in healthcare where the stakes are very high and there's possible legal ramifications if you don't do things right. So I agree, we do need to do better, but I think it also starts from putting more emphasis on primary care in medical training, because that's not done very well, at least at medical schools. And then also focusing on rural primary care. And those are big asks because primary care has been struggling to get on different agendas for a long time. And then rural health is even more marginal than that. It's not impossible, and I think things are happening, but we need to be louder and more active in asking for those things.
Great, that's good. I think we've got another question online from Al Winner, which touches on does Wonka give any advice and guidance on holding conversations in different languages, etc. But I think you've already answered that in terms of how that might be available to people.
So Wonka or Eureka?
Wonka was the
Wonka.
question. Yeah.
So Wonka has tried to make itself in general more accessible, and I think it does translate most of its events now to Spanish, Portuguese, French, Russian sometimes, and sometimes Chinese. So yes, they're doing better, but not all languages are covered. But it's worth having a look at the Wonka website, and you'll be able to work it out from there.
That's brilliant. Thank you. And also really does bring us into a discussion we've been having in rural healthcare Wales in the last 2 or 3 weeks, really, around looking at the support that happens and the networks that we have across our patch. And we're working on setting up a network for people to actually join up and work together on that across the Mid Wales patch. And Anna's pushing the agenda forward on that in terms of getting that into the joint committee. So thank you for that. Again, brilliant in terms of the insight and the visit to your personal journey as well. And thank you for sharing that, Veronica. Thank you very much. Thank you. Right, now life gets complicated, okay, everybody, because we're going to do what we call the well-being trip now, because everybody has to now move around slightly. So we're going into breakout sessions now. Breakout presentation number 1 in here, which is we know we need to do something different. And that's Powys Health Board, Julia. Well, the Julias, I think, is the answer to that one in terms of in here. In the International Pavilion over the drive there, a real-world evaluation of technology-enabled care with heart failure patients. That's happening on the ground floor. And then on the first floor in the International Pavilion, we are having a presentation on delivering a sexual assault referral centre to support victims and survivors of serious sexual assault in Mid and West Wales, something that I'm particularly keen on, as well, as some people will know. So that's what we're doing now. We're going to be back then for lunch at 12, and 12 until 1 is lunch and posters. Please make sure the posters feature in your lunch. There's plenty of time there. An hour's lunch break is pretty generous. So in terms of the next stage, that's where we're at. So if people want to make their way to where they're going now, and then we'll kick off, and we'll kick off in here. Thank you. Those people online, you will have been given a hyperlink, I think, to join the room that you're going to. I don't know about everybody else, but I'd like lunch. So I'm going to make sure the 1 o'clock deadline is hit. So we need to be really moving on. It's good for us to walk about and move around, and then we'll get on with the session in here, if that's okay. Okay, thank you, everybody. I'm now going to introduce the Julias, Julia Williams and Julia Toy. We called them, I called them the Juliettes earlier on because I thought it was kind of where it happens really in a duet. And they're going to take us through. We know we need to do something different. The Powys Health and Care Academy Careers Education Enterprise Scheme. Again, really poignant title. We know we need to do something different. We do, don't we? Julia's.
Thank you, Pedro. Right, Borodale, good morning, everybody. I'm Julia Toy from Powys Health and Care Academy, which is hosted by Powys Teaching Health Board. To my left here, we have Julia Williams, who's a nurse by background and a member of the education team in the Academy. And hopefully online, we have our colleague Anne-Marie Mason, who's another member of the team joining us virtually. So, a lot of what you're going to hear today is around the theoretical underpinning. Then we're going to talk you through what we've actually been doing in the last academic year. Maybe getting towards 2/3 of people who didn't know what they wanted to do when they had to make some really important choices about their careers. Right, sit down, please. Thank you very much for joining in. We've got another question now, though. Another stand-up question. Stand up if you were doing now, at this stage of your career, what you thought you would be doing when you were 14. Yes, Jane from the library has stood up. So we have a 1%-ish response rate there, that 1% of the people present in this room knew what they were going to do when they were 14. And that's really where we're coming from with the Academy Careers Enterprise Scheme. So I'm going to talk you through a bit of the theoretical underpinning for this work now. So there's a wide evidence base out there that shows that people living in rural areas have are older, less affluent, generally have lower education and have poorer access to preventative health programmes. And that's been picked up in some of the earlier presentations. There are generally higher levels of rural clinical workforce turnover than in urban areas. That has all sorts of impacts in terms of using more agency staffing, which is detrimental to financial balance, continuity of care, staff safety and population health outcomes. Shortages of staff in rural areas are exacerbated by a small potential workforce because of the low population density. And there's a higher proportion of elderly residents. And as a number of the poster presentations have picked up in particular today, poorer access to public transport, enabling people to get around. What we do see from the theoretical evidence base is that you can't, we have to address this pull of clinicians into urban areas. We've got to do something different, otherwise rural populations are not going to be served adequately. The other thing that we need to bear in mind, and Veronica, who was just on the podium, picked up on this, is this issue of urban centres, urban models of care. Rural services often rely on informal resources available in the local community. And that's why having carers and the third sector as part of the Powys Health and Care Academy is an integral part of our approach. So just a few little bits of information here relating the global position to Wales and Powys. Around half the global population lives in a rural area, but is served by just 38% of the nursing workforce and 24% of the medical workforce. In Wales, 1 in 3 people live in a rural area, and Powys is the most sparsely populated area of the whole of England and Wales. Recruitment and retention is recognised in all our strategic documents as a major challenge across all staff groups in Powys, across health and social care. And we know from the evidence base that there's a need for long-term, multifaceted interventions to help boost retention in rural services. Just in the last couple of weeks, the Chief Medical Officer for Wales and the Chief Medical Officer for England in their annual reports have confirmed that the shift in rural and coastal areas towards more older people and fewer people of working age presents an ongoing challenge. And the other thing that we don't often bear in mind is that health and social care are fishing in the same small pool of people for our paid workforce. And so in Powys, the approach we've taken is to join together and look at ways of working together rather than competing for people. And that reflects more integrated ways of working across professions as well. And so in summary, what we know from the evidence base is that if we give early exposure to careers information, plus frequent opportunities to experience working in or alongside services with supportive mentoring, as Veronica just picked up on, is that young people from rural areas are more likely to be attracted to and stay in health and social care careers, enabling us to grow our own future workforce. So Julia Williams is now going to talk you through what we did in the last academic year and this academic year.
Thank you, Julia Toy. Borazar, everybody. So as Julia alluded to, we are now going to go on to talk to you about our schools pilot that happened in the last academic year. So in 22-23, we worked with 2 Powys high schools, Ysgol Llanfellin and Crickhowell High School, and we concentrated on those students in sixth form who were undertaking a level 3 health and social care qualification, so for example, A-level BTEC. We delivered specific sessions. We managed to secure guest speakers to speak with those students about their career, how they got there and what they might do in their day-to-day role. And we also delivered practical sessions and simulation sessions as part of that. We had an overall of 242 interactions with the students in that year, and it soon became apparent that whilst we were able to enhance their learning, we were also able to guide and encourage them to think about health and social care and begin their journey as a career in the sector. So I want to share with you now our learning from that pilot year and how it's informed our approach to this academic year's schools initiative. So we gained feedback from students and teachers at varying points of the pilot. Initial feedback from students after one session was really positive. Themes such as they were motivated and excited. One particular student said it was better than reading books, so fantastic. But essentially, the experience and the real knowledge that practitioners could bring to the students was invaluable at giving them an insight into the health and social care sector. Then we go on to look at the midway feedback. So this was gathered from students and teachers. Again, students really excited, really enjoyed the sessions. And the only suggestion on how we could improve those sessions was they wanted more. Similarly, teachers were really pleased with the sessions and they stated that real professionals discussing their roles was more inspirational for students and teachers. And the teachers felt that it had impacted highly on the students. Then we come on to the final feedback. So here we're talking about the students. Again, we continued with the theme of enjoyment, Practical sessions were really enjoyed, and that consisted of things like taking blood pressures, learning about sensory loss with earphones and so forth. And on the whole, students felt that the sessions had helped guide their future career choices. We've included a pie chart here for information. We were unable to evidence the shift in attitudes because we had been unable to differentiate between different year groups and different students because the data was anonymised. Therefore, this year in our upcoming project, we've been sure to adapt our approach to that evaluation and feedback as a result. The final feedback here from teachers had a fantastic response and really showed that the sessions that helped engage students, it had actually helped their recall of information when it came to assignments and exams. It had really brought health and social care to life, and the students had been made more aware of health and social care careers as a result. And 100% of the teachers wanted the sessions to continue. So the positive outcomes from this pilot have led us onto the programme that we're going to go on to tell you about, that is starting in this academic year. And developing the sessions, managing the evaluation, as well as understanding school logistics has all been possible from this pilot that I've just explained to you all. So let me introduce to you the Academy Careers Education and Enterprise Scheme. So this is the start of the journey for many young people in Powys within the Academy, and it is developed from what was an ad hoc approach to a very coordinated approach on a larger scale. So the aim for this year is we want students to understand the huge variety of roles and entry routes available to them so we can grow our own future workforce in Powys. The appetite for this year has been fantastic, and our projected reach is up to 5,000 students in Powys. It has been co-produced with education colleagues and it is inclusive, so we have fully bilingual resources, but we are also able to deliver in Welsh in those schools that are dual stream. We also have an individualised approach for those additional learning needs units and pupil referral units. All the resources have been quality assured through a steering group consisting of health and social care partners as well. And of course, the evaluation from this project will go on to inform future work that we undertake. So I'm just going to run you through a little bit of what that looks like, that Academy Careers Education and Enterprise Scheme. And it's broken down into 5 phases. The first 4 phases are for all students, so all students aged 11 to 18, so year 7 to year 13. Okay. Now, as you can see from the first phase, is very much an introduction into health and social care. So what is health and social care? And we include things about the importance of Welsh in the workplace. Being the first year, that is repeated for every single year group, but we add on age appropriate material as we go on through the ages. So for example, in year 9, we talk about GCSE options that the students might be considering. In year 10, we ask them to think about the life skills that they might already have and how they could be transferable to a health and social care career. And then in year 11, 12 and 13, we introduce them to opportunities such as volunteering, apprenticeships, work experience. And the first of these sessions will begin next Monday. We're very excited for it, and it's taken a lot of preparation to get where we are, but fingers crossed, all goes well. The sessions will be delivered by the Academy team, so myself and my colleagues, but also with partners from across the Council and the Health Board. Then the final phase is very much a culmination of last year's pilot and our experience that we gathered from that. So phase 5 concentrates on working with college and high school students in years 12 and 13 who have chosen a health and social care qualification. So again, we aim to build their knowledge, but inspire them to think about their health and social care career journey, delivering specialist sessions, delivering simulation learning experiences and practical sessions as well. We've got some photos here from some of the simulation sessions. So Ysgol Maes y Dderwyn were one of the first schools that attended our academy site in Brontless, and feedback was really encouraging from that session. They said they'd been able to see snippets of careers they were interested in. We are also carrying out careers festivals as part of this approach. So in February, we will be undertaking a North and a South County Careers Festival, where we invite health and social care practitioners in to talk about their roles, as well as other colleagues. I know we've managed to ask Claire from Parvo this morning to join us to show students that they are not going to go perhaps in as the chief executive of Parvo, but actually the way people get to where they want to be in their career can be really varied, but always to aim high. So I've just got a couple of slides to show you that we use with the students. This is our mannequin who comes along with us to the sessions. It's been nicknamed Bob. Poor Bob, as you can see, has had a terrible accident and his leg's off. But we use this to ask students to think about what health and social care professionals might be involved in Bob's care, diagnosis, treatment. And we expect answers such as maybe X-ray. They might know the term radiologist. They might think of a support worker in the community who might be delivering care in their home, and so forth. Lovely. Yeah. So this next slide is one that we show the year 9 and above students. So what we aim to do here is to link careers to subjects they might enjoy. And this includes a variety of roles, so it's not always hands-on, clinical, service user-facing roles, because actually we need all sorts of people to make health and social care work. So we just sort of talk them through a couple of different topics, subjects that they might like, and the careers that they could take from that. Reminding them always the importance of Welsh, but we go into that in depth in every session that we do with students. And then this slide is one that we use with year 10 and above. So we ask the students to recognise their strengths. So any skills that they might already have from clubs, team sports, part-time job roles, we ask them to consider how they could use those in health and social care. And then we direct them to the Regional Partnership Board website, where we've got information on volunteering, work experience, apprenticeships, all together. So hopefully we can signpost them in that way. So the next steps and the planned impact of this project is that it's projected that our sessions will help students to make more informed decisions about their future career choices. We will be keeping in touch with the students with their consent for those in year 12, 13 or in college. And what we aim to do by that, we aim to develop a newsletter that we can send them on a quarterly basis, just to remind them, hello, Powys is here, look at the opportunities that we've got. We also will give them a link to sign up to volunteering opportunities, apprenticeships, work experience, and also with our temporary staffing unit in the health board. Again, as we mentioned earlier, all the evaluation data from this year will be gathered and will inform the future work that we undertake in the academy. I'll hand back to Julia Toy to tell you all about that. Okay, so this is our learning year. To go from 242 contacts with young people last year to around 4,500 to 5,000 this year could be seen as quite intimidating, but we're not focusing on that because we're starting on Monday. We're just looking at the positives. So pre and post session evaluation is going to be undertaken in every setting so that we can understand the impact, what works well, and maybe things that we need to change. Particularly with the phase 5 year learners, that's our year 12s, year 13s, we're going to be tracking them through the year through the use of anonymised identification numbers.
So most of those phase 5 learners have already been into the simulation suite in Brontleys for their first contact with the academy this year. They're going to be meeting with us again when we go into the schools over the forthcoming weeks, and then hopefully we'll see them a third time at the careers festivals in February. So we want to track from the start of this academic year through to the end of the academic year, what, if any, impact our intervention has had with them on their attitudes towards health and social care careers. We're yet to work up our approach to evaluation in additional learning needs or pupil referral unit settings, and we will co-produce that with the schools and settings themselves. Interestingly, one of the limitations that we've come across that we weren't expecting was around data capture. Some of the IT infrastructure in some of the schools is not what we were expecting. And so in some cases, we are resorting to taking out paper copies of our evaluation forms with us for the learners to fill in, and then we will do a manual input, although we've got some very clever people working on an IT scanning solution for us as well. We're taking the view that as this is our learning year, it's really important we capture as much data as possible, and we're prepared. We'd rather have paper-based data than no data at all. And at the conclusion of our work with the schools around April time, around the Easter break, we'll be undertaking a full evaluation of this year's activity, so that we understand what the impact has been and what, if any, we would like to change for the future. We are hoping that this is going to be the start of an annual cycle of activity with secondary schools in Powys. The head of education has already answered us when we're going into primaries, which freaked us out a little bit, but it's great that our education colleagues are so on board with this scheme. So in terms of the ACES scheme, that's what we've got planned for this year. But just as a reminder for colleagues, those of you who are based in Powys or academic institutions, partners, the Health and Care Academy is here to support the development of workforce solutions in Powys. If anyone today who's here is interested in partnering with the Academy on a specific project or initiative, please get in touch. Or if you're working elsewhere and would like to come and work in Powys, have a look at the Health Board or the Council websites. We've got lots of lovely opportunities to offer you. Happy to take any questions. Cheers.
Thank you for that. I'm not sure we cleared the advertising, but anyway, there we go. I'm sure every other health board and local authority in Wales would say the same thing. So good opportunity, well taken. In terms of where we're at with this, there's an added benefit, isn't there? Because we're also educating these people about health and social care as well as we go through the process, which is fantastic. And I reiterate the need to get this into primary schools as well at some point. And I know that's running before we can walk, but really good stuff. So we're up for questions now. If there's any questions in the room to start with, I haven't got anything on my screen buzzing at me, so. There's a question there at the front. I'm sorry, you're going to have to do 14 tasks now, aren't you? Have I lost my online as well now then? No. I'm okay. Thank you.
Very, very different questions that parents have, what their concerns are around health and social care as a future career, and really thinking about the influence of parents in terms of ultimately the choices that those students make, and particularly parents understanding around sport, student loans, all kinds of things, but really the parents. There's a lack of understanding about the opportunities in health and social care and why they wouldn't necessarily promote that as an opportunity for management.
Thanks. It's Jackie, isn't it? Yes. Yeah. Thanks, Jackie, for your question. We discussed parents quite early on, and actually whether we needed to do something to reach out to parents in support of the scheme. And it's something that we may well do in the future.
So open another mailbox, okay?
Sorry, that somebody who's online may wish to mute.
Could we, everybody online, please mute? Otherwise, we'll know what your shopping list is for next week. Thank you.
The phone email
Hopefully
address
that's what
then.
it's gonna be.
So yeah, completely take on board your comment. It's really interesting in the literature around grow our own future workforce. So rural roots, rural origin is a really big indicator of a person's ability and willingness to work in a rural or coastal environment. And some of that has to come from knowing about a career, but also being supported by their community, including parental support, to undertake that choice. So it's something we'll bear in mind for the future, but at this point, we just don't have the resource within the team. When we started on this year's planning and started engaging with the education colleagues in Powys County Council and the schools in April, May last year, I think it was, Julia. Yeah. Our target for this year was to get into 4 schools, and we've had 10 plus ALN plus pupil referral unit and the 2 college campuses sign up with us. So demand for this has far exceeded what we expected. And so we're focusing on the learners in this first instance, and then we're going to take over the world one step at a time. Do you have anything you want to add?
No, absolutely.
Thank you for that. We got time for one more question if there is one. I'm not going to force one, but if there is one, we can take it. Anything online? Like an auctioneer, isn't it, waiting for the online bids to come in? No, there's nothing from online. So thank you both very much for that. Very inspirational and very forward looking. I suppose a quick question for me is, have you made contact with people in the same positions in other areas so that we can spread this across the regional area? Because very often that's kind of where it falls over a little bit. We don't spread the learning very well. So brilliant. Thank you. Thanks for that. Right. Thanks, everybody, for that. My watch says it's 1 o'clock, which is lunchtime. We have to be back on a time. So, 12 o'clock, sorry. Am I talking about 1 o'clock? We have to be back on time for 1 o'clock for our bite-sized presentations exercise. That's a bit like a marathon. So, and we need to be really clear on how we get through that. We've got to be on time. So thank you all very much. We're going to lunch now and back for 1 o'clock, please. Don't forget posters and scoring of posters is a really important part of the event, and it's really good for learning for the people who've taken the time to do those posters. Thank you all very much. Thank you.